I witnessed, recorded, and produced these videotapes of the Washington, D.C. hearing. Their authenticity is above question.
This is produced as part of the ongoing work on the website, thewaythetruthandthelife.net.
This is a hearing about the government licensing the electrocution of people to cause grand mal seizures. Think of the millions of dollars, taxpayers' money, spent to pay psychiatrists and their supporters and for the worldwide travel in putting this conference together, while the victims and opponents had to pay their own way.
Good morning, everybody. I appreciate if you can get going. I guess for our panel, it was the easiest to arrive here this morning on time. They simply came straight from the conference room where they worked all night. I really, since I probably will not be at the mic anymore, on behalf of the NIH and NIMH, want to thank the panel for their spending dedication, the team spirit. I have to say, for among those conferences I've seen, this panel has been outstanding in terms of working together, everybody contributing immensely to a very focused debate, and that's what the reason that we're in session just about until the time we had to leave to arrive here. I just want to briefly outline the procedure we'll follow this morning. The chairman, Dr. Rose, will read the draft consensus statement to you, the entire document. After the reading, he will then take comments and questions from the floor on a question by question, beginning with question 1 through 5. We have asked Dr. Rose to recognize people from among those that will raise their hand in the crowd. That way, we'll ensure that the panel receives all the feedback from the speakers who presented the data, and will make sure that the panel has appropriately interpreted this data. That is the purpose primarily of this morning's session. At the same time, we have asked Dr. Rose to make sure that he recognizes those people who are likely to express an opinion other than that expressed in the document. So we'll have all of you express, but we'll recognize people from their seats to take the standby microphone. We'll also avoid the complaint we've heard that people had backs and other aches and pains from having to stand by the mic for almost an hour. So with that, we have a long morning, and I'll call for Dr. Rose to pick up.
Good morning. This is the consensus statement developed by the panel on ECT, electroconvulsive therapy. Introduction. Electroconvulsive therapy, ECT, is a treatment for severe mental illness in which a brief application of electric current is used to produce a generalized seizure. In the United States in the 1940s and the 1950s, the treatment was often administered to the most severely disturbed patients residing in large mental institutions. As often occurs with new therapies, ECT was used for a variety of disorders, frequently in high doses and for long periods. Many of these efforts proved ineffective, some even harmful. Moreover, its use as a means of managing unruly patients for whom other treatments were not then available contributed to the perception of ECT as an abusive instrument of behavioral control. With the introduction of effective psychopharmacological medications and with the development of judicial and regulatory restrictions, the use of ECT in these institutions has waned. Treatment is now used primarily in general hospital psychiatric units and in psychiatric hospitals for the treatment of severe depressions, mania, and certain types of schizophrenia. The National Institute of Mental Health Hospital Survey estimated that 32,384 patients admitted to hospital psychiatric services during 1980 were treated with ECT, representing approximately 2.4% of all psychiatric admissions. Although ECT has been used for more than 45 years, there is continuing controversy concerning its efficacy, complications, the disorders for which it is indicated, the optimal methods of administration, and the extent of its usage in various settings. These issues have contributed to concerns about the potential for misuse and abuse of ECT and desires to ensure protection of patients' rights. At the same time, there is concern that the curtailment of ECT use in response to public opinion and regulation may deprive certain patients of a potentially effective treatment. In the recent decades, scientists have intensified research efforts to establish the effectiveness of ECT and its indications, understand its mechanism of action, clarify the extent of adverse effects, and determine optimum treatment technique. This research effort has yielded substantial information that is relevant to the professional and public discussion regarding the safety and efficacy of ECT. In an effort to resolve questions surrounding these issues, the National Institute of Health, in conjunction with the National Institute of Mental Health, convened a consensus development conference on electroconvulsive therapy on June 10 through 12, 1985. After 1.5 days of presentations by experts in the field and discussion by the audience, a consensus panel including representatives of psychiatry, psychology, neurology, pharmacology, epidemiology, ethics, and law, and the general public considered the scientific evidence and agreed on answers to the following questions. What is the evidence that ECT is effective for patients with specific mental disorders? What are the risks and adverse effects of ECT? What factors should be considered by the physician and patient in determining if and when ECT would be an appropriate treatment? How should ECT be administered to maximize benefits and minimize risks? What are the directions for future research? The first question, what is the evidence that ECT is effective for patients with specific mental disorders? Published controlled studies of ECT permit evaluation of its short-term efficacy in severe major depressions, delusional and endogenous, in acute mania and in certain schizophrenic syndromes. The available controlled clinical trials do not extend beyond the treatment of the acute episode, but for about 4 weeks. These studies are difficult to interpret because they have used differing diagnostic systems and research designs. Further, they have measured outcome only in terms of symptom reduction and not quality of life and social functioning. Depression. Studies of ECT in depression have used various control conditions for comparison, including, quote, sham ECT, that is all the elements of the ECT procedure except the electric current, tricyclic antidepressants, monoamine oxidase inhibitors, combinations of antidepressants and neuroleptics, and placebos. The efficacy of ECT has been established most convincingly in the treatment of severe delusional and endogenous depressions, which make up a clinically important minority of depressive disorders. Some studies find ECT to be of at least equal efficacy to medication treatments, and others find ECT to be superior to medication. Not a single controlled study has shown another form of treatment to be superior to ECT in the short-term management of severe depressions. It must be noted, however, that those studies that found ECT to be superior to medication do not document any advantage for ECT beyond the short term. Moreover, the available evidence suggests that relapse rates in the year following ECT are likely to be high unless maintenance antidepressant medications are subsequently prescribed. Several studies suggest that ECT reduces symptoms in severely depressed patients who previously have not responded to adequate trials of antidepressant medication. The literature also indicates that ECT, when compared to antidepressants, has a more rapid onset of action. Delusional depression. ECT is highly effective in the treatment of delusional depression. It is superior to either antidepressants or neuroleptics used alone, and is at least as effective as the combination of antidepressants and neuroleptics. ECT is often effective in patients who have previously failed to respond to medication. The duration of therapeutic effect beyond the initial acute episode is not clear. Endogenous melancholic depression. The severe endogenous melancholic depressions are characterized by early morning awakening, marked weight loss, psychomotor retardation and/or agitation, diurnal variation, and lack of reactivity. ECT is at least as effective as tricyclic antidepressants and more effective than sham ECT in the short-term treatment of these severe endogenous melancholic depressions. ECT appears to be more effective than monoamine oxidase inhibitors in the treatment of severe depressions, but available studies have generally used relatively low MAOI doses. The long-term efficacy of ECT with endogenously depressed patients is unknown. There is evidence for the efficacy of ECT in those endogenous depressives who have not responded to an adequate trial of antidepressants. Other depressions. The majority of depressed persons encountered in medical and psychiatric settings do not have the severe endogenous melancholic or delusional depressions described above. ECT is not effective for patients with milder depressions, that is, dystonic disorder, neurotic depression, and adjustment disorder with depressed mood. While patients with major depression, that is non-endogenous, non-melancholic, have not been directly studied using the current DSM-3 nomenclature, their similarity to other, less severe forms of depression suggests that ECT would not be effective for them. Acute manic episode. ECT and lithium appear to be equally effective for acute mania, and both are superior to hospitalization with no somatic therapy. A treatment regimen in which ECT is used for the acute episode, followed by lithium maintenance, does not appear to be associated with increased risk of early relapse compared with lithium treatment alone. Schizophrenia. Although neuroleptics are the first line of treatment for schizophrenia, ECT may sometimes be effective. ECT is generally more effective for those schizophrenics with a shorter duration of illness, a more acute onset, and more intense affective symptoms. ECT has not been useful in chronically ill schizophrenic patients. Although ECT is frequently advocated for treatment of patients with schizophreniform psychoses, schizoaffective disorders, and catatonia, there are no adequate controlled studies to document its usefulness for these disorders. Other disorders. There are no controlled studies supporting the efficacy of ECT for any conditions other than those designated above. That is, delusional and severe endogenous depression, acute mania, and certain schizophrenic syndromes. What are the risks and adverse effects of ECT? That's question number 2. To maximize the benefits of ECT and minimize the risk, it is essential that the patient's illness be correctly diagnosed, that ECT be administered only for appropriate indications, and that the risks and adverse effects be weighed against the risks of alternative treatments. Risks and adverse effects of ECT can be divided into 2 categories. Those that can be substantially reduced by the use of appropriately trained staff, best equipment, and best methods of administration, and 2, Those, such as persistent memory loss and transient post-treatment confusion, which can be expected even when an optimal treatment approach is used. In this report, we will focus on the risks of adequate treatment, which now includes the use of short-acting anesthetics, muscle relaxants, oxygenation, and a well-trained staff and modern equipment. In the early days of ECT, mortality was a significant problem. The commonly quoted mortality rate in the first 2 decades was 0.1% or 1 per thousand. Over the years, safer methods of administration have been developed. Present mortality is very low. In the least favorable recent study series reported, there were 2.9 deaths per 10,000 patients. In another series, 4.5 deaths per 100,000 treatments were reported. Overall, the risk is not different from that associated with the use of short-acting barbiturate anesthetics, such as those used for dental procedures. Nevertheless, the potential for death from improperly administered anesthesia is ever present and should be considered when evaluating the setting for performing ECT. In the past, up to 40% of patients suffered from various complications, the most common being vertebral compression fractures. With present techniques, these risks have been virtually eliminated. In one large study of almost 25,000 treatments, a complication rate of 1 per 1,300 to 1,400 treatments was found. These included laryngospasm, circulatory insufficiency, tooth damage, vertebral compression fractures, status epilepticus, peripheral nerve palsy, skin burns, and prolonged apnea. During the few minutes following the stimulus, profound and potentially dangerous systemic changes occur. First, there may be transient hypotension from bradycardia, caused by central vagal stimulation. This may be followed by sinus tachycardia and also sympathetic hyperactivity that leads to a rise in blood pressure, a response that may be more severe in patients with essential hypertension. Intracranial pressure increases during the seizure. Additionally, cardiac arrhythmias during this time are not uncommon, but usually subside without sequelae. Thus, certain patient groups that would be adversely affected by these manifestations are at increased risk. Central nervous system effects can be divided into 2 categories: the immediate consequence of the ECT seizure and the more enduring effects whose severity is affected by the treatment course. Immediately after awakening from the treatment, the patient experiences confusion, transient memory loss, and headache. The time it takes to recover clear consciousness, which may be several hours, varies depending on individual differences in response, the type of ECT administered, and the spacing and number of treatments given. The severity of this post-ECT syndrome is greatest after bilateral sine wave treatment and least when non-dominant unilateral pulse ECT is administered. Severity also appears to be increased by longer seizure duration, closer spacing of the treatments, increasing dosage of electrical stimulation, and each additional treatment. With a small number of treatments generally used, however, the number of treatments may not have a significant effect on the nature of the acute confusional state. Depressive disorders are characterized by cognitive defects that may be difficult to differentiate from those due to ECT. It is, however, well established that ECT produces memory deficits. Deficits in memory function, which have been demonstrated objectively and repeatedly, persist for several months after the termination of the normal course of ECT. Severity of the deficit is related to the number of treatments, type of electrode placement, and nature of the current. Greater deficit occurs from bilateral placement than from unilateral placement, but unilateral treatment may be less effective. Sine wave current has been found to impair memory more than pulse current. Enduring or permanent gaps in memory have been reported to occur for events occurring during the 6-month period before ECT, retrograde amnesia, and during the 2-month period after treatment, anterograde amnesia. Although the ability to learn and retain new information may return to normal in several months after the termination of ECT, significant treatment-related gaps in memory may persist. The extent of the memory deficit varies from one patient to another. Because there is also a wide difference in individual perception of the memory deficit, the loss can be extremely distressing to some and of little concern to others. Many patients complain their memory is not as good as it was formerly for as long as 3 years after treatment, although this deficit has not been established by neuropsychological testing. There is no consistent evidence of change in other cognitive functions such as attention or learning. There are other possible adverse effects from ECT. Some patients perceive ECT as a terrifying experience. Some regard it as an abusive invasion of personal autonomy. Some experience a sense of shame because of the social stigma they perceive as attaching to ECT, and some report extreme distress from persistent memory deficits. The panel heard eloquent testimony of these attitudes from some patients who have been treated with ECT. It is clear, however, that these attitudes are not shared by all ECT patients. The panel also heard moving testimony from former patients who regarded ECT as wholly beneficial and life-saving experience. There are insufficient systematic studies to permit any definitive assessment of the prevalence of these various perceptions among ECT patients. Numerous studies have been conducted in animal models of ECT. Many of these suffer from methodological shortcomings. In studies that have been controlled for fixation artifacts, hypoxia, and other methodological problems, neuronal cell death has not been detected. Cerebral vasospasm and alterations in capillary permeability are of short duration and of insufficient magnitude to lead to neuronal cell death. The precise mechanism of the anterograde and retrograde memory deficit has not been established. It may represent alterations in neuronal function that are not detectable with present methods. Computerized axial tomography or CAT studies of patients who have had ECT are very preliminary and open to alternative interpretations. Studies of in vitro brain metabolism with positron emission tomography, PET, and studies of tissue change detectable by magnetic resonance imaging, MRI, remain to be done. The third question. What factors should be considered by the physician and patient in determining if and when ECT would be an appropriate treatment? The consideration of ECT is most appropriate in those conditions for which efficacy has been established. Delusional and severe endogenous depressions, acute mania, and certain schizophrenic syndromes. ECT should rarely be considered for other psychiatric conditions. The decision whether to offer ECT to an individual patient should be based on a complex consideration of advantages and disadvantages for ECT and for each treatment alternative. Whether or not to use ECT should be based on a thorough review of severity, medical indications and contraindications, and non-responsiveness to other treatments. It should be emphasized that for certain patients with very specific and narrow indications, ECT may be the only effective treatment available. The panel wishes to assure that ECT is only administered for the benefit of individual patients. Institutional factors such as financial pressures created by prospective systems or staff convenience should play no role in the decision to administer ECT. Severity. Given a diagnosis for which the efficacy of ECT has been established, the immediate risk of suicide, when not manageable by other means, is a clear indication for the consideration of ECT. Acute manic episodes, especially when characterized by clouded sensorium, dehydration, extreme psychomotor agitation, high risk for serious medical complications, or death through exhaustion, and non-response to pharmacological interventions are also clear indications for ECT. The severe and unremitting nature of a patient's emotional suffering or extreme incapacitation are also important considerations. Medical indications and contraindications. The patient's medical status is often the determining consideration in the use of ECT. ECT may be necessary when the patient has medical conditions that preclude the use of tricyclic antidepressants, monoamine oxidase inhibitors, lithium, and neuroleptics. Severe depression or psychosis during the first trimester of pregnancy may also suggest the use of ECT. Conversely, space-occupying lesions in the brain, increased intracranial pressure, a recent history of myocardial infarction, and aneurysm are contraindications for ECT. A personal history of ECT non-responsiveness or debilitating side effects, medical or psychological, are also important contraindications. Non-responsiveness to other treatments. ECT should be considered when alternative pharmacological and or psychotherapeutic treatments have been given an adequate trial without efficacious response. In treatment non-responsive patients, factors such as severity, the natural course of the patient's illness, and the risk of worsening the course of illness, for example, exacerbation of the course of bipolar illness by antidepressant medication, need to be taken into account. Informed consent. When the physician has determined that clinical indications justify the administration of ECT, the law requires and medical ethics demand the patient's freedom to accept or refuse the treatment to be fully honored. An ongoing consultative process should take place. In this process, the physician must make clear to the patient the nature of the options available and the fact that the patient is entitled to choose among these options. No uniform shopping list, quote, can be drawn up regarding the matters that should be discussed by the patient and physician to assure a fully informed consent. They should discuss the character of the procedure, its possible risks and benefits, including full acknowledgement of the attendant uncertainties, and the alternative treatment options, including the option of no treatment at all. Special individual needs may also be relevant to some patients. For example, personal situations that require rapid recovery to facilitate return to work and to reduce family disruption. In all matters, the patient should not be inundated with technical detail. The technical issues should be translated into terms meaningful and accessible to the patient. It is not easy to achieve this ideal of informed consent in any aspect of medical practice, and there are special difficulties that arise regarding the administration of ECT. In particular, the patients for whom this procedure is medically appropriate may be suffering from a severe psychiatric illness that, although not impairing their legal competency to consent, may nonetheless cloud their judgments in fully weighing all of the available options. Such judgmental distortion does not justify disregarding the patient's choices. Rather, it makes all the more important that physicians strive to identify and clarify the options that the patient alone is entitled to exercise. The consent given by the patient at the outset of treatment should not be the final exchange on this issue, but should be re-examined repeatedly throughout the course of the treatment. These periodic reviews should be initiated by the physician and not depend on patient initiative to, quote, rescind consent. There are several reasons for this repeated consenting procedure. Because of the relatively rapid therapeutic effect of the procedure itself, the patient, after initial treatment administrations, is likely to have enhanced judgmental capacities. The risk of adverse effects increase with repeated treatments. But the question of continuing treatment presents a possible change, risk-benefit assessment for the patient. And because of the short-term memory deficits that accompany each administration of ECT, the patient's recollection of the prior consenting transaction itself might be impaired, so that repeated consultations reiterating the patient's treatment options are important to protect the patient's sense of autonomy throughout the treatment process. Moreover, if the patient agrees, his or her family should be involved in each step of this consultative process. In some cases, a patient will lack adequate legal capacity to consent to the proposed procedure, although such patients will most likely constitute a small minority of all patients for whom ECT is an appropriate option. In such cases, court proceedings are necessary if treatment is to be provided. Legislation in a few states provides that ECT may, in no circumstances, be provided to an involuntarily committed patient. The panel believes that such provisions are unduly restrictive and make it impossible for patients who might obtain substantial benefit at acceptable levels of risk from ECT that they could not obtain from any alternative treatment modality. It may be desirable for physicians with patients for whom the prospect of ECT is a foreseeable but not immediate possibility to discuss this in advance with the patient when his or her judgment appears least compromised by the underlying disease process. Such advanced discussion would serve as a non-binding guide both to the patient and physician and would be another means to enhance the patient's autonomous choice in weighing the risks and benefits of this procedure and its alternatives. Question 4. How should ECT be administered to maximize benefits and minimize risks? Once the patient and physician have decided that ECT may be indicated, the patient should undergo a pre-treatment medical examination that includes a history, physical, neurological examination, EKG, chest films, and laboratory tests. Medications that affect the seizure threshold should be noted and decreased or discontinued when clinically feasible. Monoamine oxidase inhibitors should be discontinued 2 weeks before treatment, and patients should be essentially lithium-free. Severe hypertension should be controlled before beginning treatment. Because some patients with compromised cardiovascular status will be receiving ECT, cardiac conditions should be evaluated and monitored closely. Educate the patient and the family through discussion and written and or audio-visual material describing the procedure as necessary prior to obtaining written informed consent. An area should be designated for the administration of ECT and for supervised medical recovery from the treatment. This area should have appropriate healthcare professionals available and should include equipment and medications that could be used in the event of cardiopulmonary or other complications from the procedure. An anesthesiologist or anesthetist experienced with brief anesthetic procedures should administer the anesthesia. The treatment team should include nursing personnel trained in ECT procedures and recovery. ECT is ordinarily given in the early morning after an 8 to 12 hour period of fasting. Atropine or another anticholinergic agent is given prior to the treatment. An intravenous line is placed in the peripheral vein, and access to this vein is maintained until the patient is fully recovered. Methylhexatol is given first, followed by succinylcholine for muscle relaxation. Ventilatory assistance is provided with a positive pressure bag using 100% oxygen. The EKG, blood pressure, and pulse rate should be monitored throughout the procedure. Stimulus electrodes are placed either bifrontotemporally, bilateral, or with one electrode placed frontotemporally and the second electrode placed on the ipsilateral side, unilateral. Bilateral ECT may be more effective in certain patients or conditions. It has been established, however, that unilateral ECT, particularly in the non-dominant side, is associated with a shorter confusional period and fewer memory deficits. Also, a brief pulse stimulus is associated with fewer cognitive defects than the traditional sine wave stimulus. Seizure threshold varies greatly among patients. Therefore, the lowest amount of electrical energy to induce an adequate seizure should be used. Seizure monitoring is necessary and may be accomplished by an EEG or the cuff technique. In unilateral ECT, the cuff should be on the same side of the electrodes to ensure that a bilateral seizure occurred. Further work integrating these variables is necessary to maximize efficacy and minimize side effects. The numbers of treatments in a course of therapy varies. 6 to 12 treatments are usually effective. In the United States, the usual frequency is 3 times weekly. In the United Kingdom, the standard practice is 2 treatments weekly. Regressive ECT, a large number of treatments given within a short period for the purpose of achieving a persistent organic brain syndrome, is no longer an acceptable treatment form. Multiple monitored ECT, several seizures during a single treatment session has not been demonstrated to be sufficiently effective to be used. There are no controlled studies on the periodic use of ECT as a maintenance regimen. Following ECT, most depressed patients should be maintained on antidepressant medication to reduce relapses. The panel is concerned that there are only limited data on the manner and extent of ECT administration in the United States and on the training of personnel involved in it. A national survey should be undertaken to assemble basic facts about the status of ECT treatment. Medical school curricula should include education in the use of ECT. Psychiatric residency programs should include complete ECT training, indications, contraindications, risk, clinical management, informed consent, and the evaluation of outcome. The American Board of Psychiatry and Neurology should include questions about ECT in its oral and written examination. The panel believes it is imperative that appropriate mechanisms should be established to ensure proper standards and monitoring of ECT. Hospitals and centers using ECT should establish review committees modeled on other medical surgical review committees and should formulate rules and regulations to govern the privileging of physicians giving their treatments. Stringent peer review, consistent with Joint Commission for the Accreditation of Hospital Standards, should monitor ongoing utilization of ECT. Periodic inspection of the equipment is also essential. As experience accumulates, consideration should be given to the adequacy of existing monitoring and review mechanisms. 5. What are the directions for future research? ECT has been under-investigated in the past. Among the most important immediate research tasks are initiation of a national survey to assemble the basic facts about patient attitudes and responses to ECT. Better understanding of negative, positive, and indifferent responses should result in improved treatment practices. Identification of the biological mechanisms underlying the therapeutic effects of ECT and the memory deficits resulting from the treatment. Better delineation of the long-term effects of ECT on the course of affected illnesses and cognitive function. Precise determination of the mode of electrode placement, unilateral versus bilateral, and the stimulus parameters, form, and intensity that maximize efficacy and minimize cognitive impairment. Identification of patient subgroups or types for whom ECT is particularly beneficial or toxic. Conclusion. Electroconvulsive therapy is the most controversial treatment in psychiatry. The nature of the treatment itself, its history of abuse, unfavorable media presentations, compelling testimony of former patients, special attention by the legal system, uneven distribution of ECT use among practitioners and facilities, and uneven access by patients all contribute to the controversial context in which the consensus panel has approached its task. The panel has found that ECT is demonstrably effective for a narrow range of severe psychiatric disorders in a limited number of diagnostic categories. There are, however, significant side effects, especially acute confusional states and persistent memory deficits. Proper administration of ECT can reduce potential side effects by also providing for therapeutic effect. A physician's decision to offer ECT to a patient and the patient's decision to accept it should be based on a complex consideration of advantages and disadvantages of ECT compared with alternative treatments. An ongoing consultative process requiring time and energy on the part of both patient and physician should occur. Much additional research is needed into the basic mechanisms by which ECT exerts its effect. Studies are also needed to better identify subgroups for whom the treatment is particularly beneficial or toxic, and to refine techniques to maximize efficacy and minimize side effects. Surveys should be conducted on the practice of ECT in the United States. These recommendations reflect the consensus of the panel. We have been careful to narrowly delineate when and how, in our judgment, ECT should be administered. To prevent misapplication and abuse, it is essential that appropriate mechanisms be established to ensure proper standards and monitoring of ECT. Thank you. The procedure now is for us to discuss the first question, which is the question of the statement on efficacy. If you raise your hand, I will call on you. As Dr. Jacoby indicated, one of our major goals this morning is to have some feedback as agreements or disagreements from the individuals who provided us with expert testimony during the course of the sessions yesterday and the day before, as well as to hear from individuals who disagreed with our conclusions. Would you raise your hand and then I can point to you? Yes, sir.
On first hearing, it seems to me that there's only one point in this statement that I, as a physician, would suggest a modification on, and that is in the statement concerning the recommendation that an anesthesiologist administer the...
Excuse me, I'm sorry, let me try to make it clear. We're going through question by question. The first question is what conditions for which there's efficacy. And we'll come to that in the fourth question. And I want to try to do that because different members of the panel have a responsibility to be ascribed to that. So if I could ask you to try to focus to the first part of our discussion on our answers to the first question. Would you raise your hand? Second.
That's a minor point, but I think there's an inaccuracy on page 5, which states that there has not been any study using current DSM-3 nomenclature on the diagnosis of undiagnosed. Studies have been published in the last year or so addressing that question. I know one was published by Electroconvulsive Therapy. Interesting, I was surprised. They found no difference in efficacy when patients were diagnosed according to
I think the panel could all hear you. Why don't you come to the microphone and make sure that so the audience can hear your comments too? I think it's very important. You can use the one up here, it's closer for you. Thank you.
I think it's a relatively minor point in the efficacy section, but I think there's an accuracy on page 5. To the extent that the statement is that there has not been direct studies using current DSM-3 nomenclature on the question of whether patients who are diagnosed as non-endogenous or non-knowing fall have different therapeutic response from those diagnosed the other way. There have been 2 such studies that have recently come.
And they show what?
And surprisingly, at least to me, they showed that there was no difference.
The ECT was not more efficacious in their use.
That both groups were responsive, endogenous and non-endogenous, using the DSM-3 nomenclature. Coriel and Iowa was the source of one of these tests.
The panel is, please feel free to ask a clarifying question.
Was there a placebo control or sham ECT or something?
No, this was this work was within a patient cohort establishing whether different diagnostic distinctions were critical to accounting for individual differences in therapeutic response.
They all have major depressive disorder?
Yes, they were all diagnosed as losing spectrum.
And were they, what was the rate?
Sorry, I can't comment.
But it was appropriately high?
Yes. Yeah, these were patients who generally were responsive.
Were these studies presented during the last 2 days?
They were not mentioned as
No.
far as I know. They were not presented. No. Just wanted you to know that the literature indicates a contradiction with the statement.
Could you provide us with the references of the names?
I can try.
Thank you. Are there any other comments? Yes, Dr. Bregan.
In regard to what Dr. Sackman said, what you're saying in your report is more consistent with conventional wisdom in psychiatry, and I don't think that 1 or 2 studies out of several thousand should change the conventional wisdom, even though I would rather not even see the conventional wisdom that's so highly promoted. I think there's a basic consistency between using terms like most convincingly to describe the effect of the treatment when in the earlier paragraph you have so clearly noted that the effect doesn't last beyond 4 weeks, as far as we know. I think that your analytic description is more accurate than your concluding evaluation. I would like to see inserted that those 4 weeks are the weeks of delirium. That is, that the only studies that show any effect in ECT, this is critical, the only studies that show any effect in ECT show an effect during the period of delirium. And if you were measuring any higher emotional response, not just depression, but the ability to love, the ability to have a religious experience, the ability to work, the ability to take care of your children adequately during that 4-week period, they would all be reduced, not just depression, so that there is a misemphasis here in the statement. In fact, during those 4 weeks, the patients are often incompetent.
I don't want to respond to that yet.
Well, we have said in our report that there have not been any studies which have used outcome measures of quality of life and social functioning, and we urge that those are the types of studies that should be done. We've emphasized that the outcome during the 4 weeks is reduction of symptoms, which seems to be documented in those studies. The reason that there's no data beyond 4 weeks is that studies are only done for 4 weeks, and after 4 weeks, the patients in both treatment groups have gotten other treatments, and therefore it's not possible to evaluate.
Dr. Brandon.
Thank you, Mr. Chairman. May I trespass slightly from my brief and congratulate the panel on the production of a remarkable document. Although I don't entirely agree with the emphasis in every respect, I think you have done a remarkable job in producing a clear and authoritative document. As far as the point which Dr. Bregan was raised, I can assure him that none of our patients had persistent delirium during that period. Many had transient delirium after treatment, but the majority showed a dramatic reduction not only in symptoms, but a marked improvement in the quality of life with total absence of delirium through that period.
Judy Chamberlain, next to the microphone, find Dr. Brennan.
Yeah, on page 3, in the first paragraph, you're talking about the available controlled clinical trials to now extend beyond treatment-acute episodes, i.e. about 4 weeks. Then just below that, in the paragraph, the efficacy of ECT has been established most convincingly in the treatment of severe delusional and endogenous depression. There's just a real contradiction there. For a study that has insisted on clinical controlled evidence in order to make any statement, it seems to me you must put in that in that statement, at the very least, the efficacy of ECT has been established for 4 weeks, and not instead of most convincingly. There's just a real contradiction.
Yes, sir.
Yes, some of the indications that you covered in some of the efficacy studies, certainly I congratulate you for limiting them to controlled data and noting when there's no controlled data. A couple of things that were left out that I would like to see included, just so that those of us that do use the treatment sometimes these indications are some of the organic depression, such as that associated with Parkinson's disease, where the Parkinson's disease itself gets better with ECT in many of the cases, not all. And the other is in the case of chronic pain syndromes associated with depression. Even though these depressions may not be considered endogenous, I think there's anecdotal data, which of course in this group I would not propose as being controlled data. I'd like to see that at least mentioned so that it wouldn't be taken as a total exclusion to use ECT in refractory cases of this type.
Does anyone want to respond to that?
Are there any controlled clinical trials that you could provide us references for?
As far as I know, there are no controlled clinical trials. There are only at most a 2 to 3 patient series where there was, again, these patients obviously were reported because they had a positive response. I would say that that's an area that needs further research. What I'm saying is I would hope that the use of ECT in those 2 situations I mentioned would not be proscriptive. But no, they're just anecdotal reports. I know that.
Alan? I think that the logic that we employed was that the indications or recommendations have to be coming from controlled trials. The issue about case reports or anecdotal reports, we're not saying that they're inaccurate, but to offer general efficacy to the treatment for those is beyond the usual and customary and reasonable scientific inference. The fact is that we did recommend that controlled trials be done in other groups to clarify it for which benefit can be obtained, but we cannot recommend treatment at this time. Dr. Prime.
Yeah, I'd like to follow up on the point by Hal and the previous gentleman, in that some depressions that do not meet the criteria for endogenous depression can be every bit as severe as endogenous depressions, including risk of suicide and severe incapacitation. Now, it's possible that ECT may prove to be effective in severe non-endogenous depressions that fail to respond to an adequate trial of antidepressants. In the statement, this possibility should not be excluded, and should the suggestion be made that ECT would not be effective for them. And what I would suggest perhaps is that on page 5, in the last sentence of the first paragraph, you might say that patients with major depression that is non-endogenous, non-melancholic have not yet been directly studied using current DSM-3 nomenclature. And instead of the last phrase, I would suggest you say that effectiveness of ECT in severe endogenous melancholic depressions that fail to respond to an adequate trial of antidepressants requires further investigation, rather than equating most of the major non-endogenous depressions with other less severe forms and indicating rather positively that ECT would not be effective for them. I think you close off a very valuable potential use of ECT with this statement.
We had a series of, I think it's important to respond because I think your comments are well taken. The issue that the group dealt with was, in the first question, to generically describe those groups for which the data was the best. In the third question, we talk about the conditions in which patients may have with varying diagnosis that speak to the use of ECT and try to clarify them. The problem, I guess, is that we are somewhat artificially taking question by question in order to facilitate the discussion, and we may attempt, perhaps we need some reference to that because we don't close the door and clarify that in number 3. But we appreciate your remarks. Yes, sir.
Can I just make a small point about the...
You might want to remind us that you're Dr. Friedman, Dr. Friedman.
About the length of course of ECT and maintenance ECT. I agree there are no clear studies on the subject of maintenance ECT. There is one interesting study which I don't think has been mentioned by Barton and Smith, which addressed the question of when symptomatic recovery is achieved, is there any point in giving 1 or 2 more treatments, the so-called one for the pop treatment, the topping up type of method that was used very extensively in the UK some years ago. And they showed very clearly that there was no point in going on with any further treatments after symptomatic recovery had been achieved. There was no prophylactic effect of giving 1 or 2 more ECT at the end of the course. I think it was worth taking up to 6-month follow-up of patients showing that you really had to stop as soon as symptoms were relieved and there was no advantage in extra treatments.
Thank you, Dr. Kuhn.
I think in light of some of the potential confusion about this 4-week effect and limited studies and how that might be misunderstood by people who don't do trials of acute treatments of all sorts, it might be good to put something in the statement to say that the evaluation of ECT as an acute treatment is very similar to the evaluation of other treatments of depression. That is, these studies are designed for brief, several-week trials. The majority of patients who complete these trials are discharged from the hospital, and that the question of recurrence of new episodes in an illness which is given to recurrences has yet to be addressed in relation to ECT, as it has been somewhat addressed in relation to other treatments. But simply to say that we don't know that it works beyond 4 weeks, I think is confusing to people who don't know the issues about how we evaluate treatments and the difference between treatment of an episode and long-term management. I think that little work on that part of the statement needs to be done.
We tried that. Obviously, we didn't do as well as we might have done. Yes, please.
My name is Margaret Bader. I'm the Florida representative of the Community for Clinical Psychiatry. I would like to address the top paragraph on page 4. Some suggest that ECT reduces symptoms and severely depressed patients who previously have not responded to adequate trials of antidepressant medication. Has there ever been any consideration that there are patients who are allergic to your antidepressant medication, therefore increasing the symptoms, creating suicidal symptoms, and making the person worse, and therefore the recommendation is given to receive ECT. I would also like to add that follow-up of determination that you have defined does not apply to certain patients. It has taken me 15 years to restore what you took away from me in a very, very hard way. I was not followed up in any way after the hospital in which I was released as cured, except to have relapses because I was on antidepressant medication, which kept sending me back to the same asylum and the hospitals and psychiatric wards. Thank you.
Yes, and then Mr. Upton after, member of the press.
Yeah, this is Calvin Pierce from Clinical Psychiatry News. It's a little well.
Take it out of the holder.
I'm interested too in the panel's statement about the long and the short-term efficacy of the treatment. We've seen a lot of statements in recent years about cardiovascular disease and cancer treatments where decisions have been made about treatment alternatives based on 5, 10, even 20-year recurrence rates, and sometimes very small differences. And I'm wondering how the panel could explain to the general public how it's able to make the recommendations it has on the basis of only 4-week duration follow-up studies.
Would someone like to try to answer the 4-week question as the gentleman asked about this? It's not a 4-week follow-up. Come on, okay?
Well, is this on?
Yeah.
I think most depression is a recurring illness, and so that you treat each episode, and I think the efficacy then is the treatment of the acute episode. It's sort of like giving penicillin for strep throat. One would not expect it to prevent strep throat 6 months hence.
I'm Edward Ogden. There are, of course, many ways in which I wish the consensus statement were written differently. I'll apply my remarks in the interest of our limited time to one sentence on page 5. In the paragraph on schizophrenia, the second sentence as it's been written reads, ECT is generally more effective for those schizophrenic patients with a shorter duration of illness, more acute onset, and more intense affective symptoms. I think that this sentence, as it's been drafted, doesn't truly is incongruent with the evidence that was presented to your panel. And so I especially regret the endorsement of ECT for schizophrenia in this document. And I will explain why, and I'll suggest a way in which it might be improved. The people diagnosed with schizophrenia historically have suffered the most frequent, the worst abuses of the ECT. And I believe that the revival of ECT as a popular treatment for schizophrenia is one of the most likely outcomes of this document. And I think the panelists would not want to fear may occur. Now, the outcome research on depression, limited as it is a model of scientific rectitude compared to the outcome studies of ECT for schizophrenia. The reason for that is that modern scientific investigators, with very few, if any, exceptions, have not been doing outcome studies on schizophrenia. I suspect that this advancement of outcome studies on schizophrenia has occurred because the modern investigators have concluded, as I have, that the older literature shows only the immediate organic brain syndrome, which of course suppresses the more bizarre and florid symptoms of acute schizophrenia. And of course also the fact that the sudden onset, first episode of schizophrenia has a good likelihood of improving with or without treatment. The evidence presented to you, the panel, at this conference was contained primarily in Dr. Small's slide, which was a slide that listed about half a dozen outcome studies on schizophrenia. I think if you would look into the references listed there, you would find, well, for one thing, you would find Exner and Murillo study, which was one of those. That was an intensive ECT study in which the patients were shocked repeatedly and frequently into a state of vegetation, where they were acute and persistent organic brain syndrome. Those investigators concluded that that status was an improvement over what they had seen before. I don't think that's what the panel would regard as real evidence of improvement in schizophrenia. And I believe if you would look at the other references there, you would find that it's impossible to tell from the other references whether there is any improvement in the patients, any different from what Exner and Murillo found.
Could we, I think one of the panel would like to respond to that, and I'd like to move on, if we could, to the next topic, because of the time.
I would like to suggest in conclusion, if I may, a way in which that sentence might be better written. If not entirely excised, which I think would be appropriate. But if not entirely excised, I think it ought to read, the evidence is suggestive of effectiveness only for those schizophrenia patients with with a short duration of illness, acute onset, and intense affective symptoms. That would cure the tendency of present wording to suggest that while it's most effective for some patients, it's also likely to be somewhat effective for others.
Thank you. Dr. Stone?
Our intention clearly was not to have schizophrenia, have ECT be the first line treatment for schizophrenia. And we specifically state that in the first sentence. And we specifically state that it is not effective for chronic schizophrenia. And in terms of the regressive shock that you described before, we again state that that is contraindicated. We stated it this way in order to have an opportunity for schizophrenic persons who did not respond to medication or could not get medication because of medical contraindications to give the practitioner some guidelines as to which schizophrenic persons might respond to ECT.
Thank you. I'd like to go on now to the second question. Dr. Lenoir, I think we have an hour to do the rest of them, and I apologize. This is now, what are the risks and adverse effects of ECT? Dr. Squire. There is not any, I would suggest that you do sit down and raise your hand, because queuing up the microphone will not yield a reinforced response, so I can't do that way. You've got to go to try to cover the people who present material. I will try to get as many people as I can. Standing the microphone will not help you with this.
I'd like to address my comments to page 8. I think there's an ambiguity in all the sensory memory functions, which we need to be as precise about as we can. In other words, one needs to be uncomfortable with the term that there are transient memory deficits after ECT, because after all, there is this permanent gap, and one needs to be uncomfortable with the term that there are persistent memory deficits because of the implication that there is a permanent loss of the learning ability. And so with that idea in mind, I have several specific comments about the wording on various parts of page 8. In the first paragraph, beginning depressive disorders, there's a sentence that reads, deficits in memory function which have been demonstrated objectively and repeatedly persist for several months after the termination of the normal course of ECT. This ambiguity has a chance of being resolved in the lower paragraphs, and I would think it might be easier and clearer at that point just to simply say deficits in memory which have been demonstrated, etc., persist after the termination of the normal course of ECT, rather than getting the timing of it, which begins to get complicated. And similarly, in the same paragraph, greater deficit occurs from bilateral replacement than from unilateral replacement, but unilateral treatment may be less effective. I think that much more needs to be said about bilateral.
Dr. Squire, could you decelerate the pace?
Oh, excuse me.
You can't write that fast.
It's not just 2 minutes.
No, we are trying, this is a different, I'm sorry to make that clear. No, we're trying to allow for longer so that people can give us the benefit of their input.
Excuse me. I would be more comfortable if at that point there was no reference to the issue of what unilateral treatment may be less effective. Perhaps something like see page 15 or something, because I'm going to have some more standard comments about bilateral and unilateral ECT when we discuss point 4, and I think that to state it in that simple way is going to be a little misleading, because I think the unilateral bilateral issue is one that again needs to be fleshed out and spoken about with a little more precision. Now becoming more concrete. My recommendation would be to delete the end of the sentence which says, but unilateral treatment may be less effective, or to insert simply a parenthesis saying, see page 15 for discussions of differences between bilateral and unilateral treatment. Now, becoming more concrete in terms of the last 5 or 6 lines of the page. The first
3 to 4 lines are not in this statement. Oh, that's the paragraph?
No. The last 4 or 5 lines of the page, what I thought I might do is just read an alternative version. Maybe that would be the simplest, and I'd be happy to make that people may find it useful. I'll read it slowly. Beginning with a sentence, many patients complain. I would perhaps say it this way. Many patients complain that their memory is not as good as it was formerly for as long as 3 years after treatment, period.
That's just what we have. That's just the same sentence we have.
With a period after the parentheses. A persisting deficit in new learning ability has not been established by neuropsychological testing. Period. neuropsychological data are consistent with the existence of a persisting gap in memory around the time of treatment, for a period of up to a few months after treatment, and for a time of at least a few weeks before treatment. The exact periods of time persistently affected before treatment are not yet established with certainty. And then finally, read that sentence one more time.
Why don't we get it?
I'll write it out. And then finally, the last sentence, there is no consistent evidence of change in other cognitive functions such as attention. But I wouldn't use the term learning. Learning, of course, is the beginnings of memory. And in fact, learning and memory are exactly what is affected. So it would not, I think, be appropriate to use the term learning there. And then finally, I wonder if I might at this point speak to page 18 in which in your summary statement, you're speaking again about the memory effects and the same ambiguity about persistent, what's persistent, what's transient comes up in the first paragraph of page 18. The second sentence, you might flesh it out in the following way. There are, however, significant side effects, especially acute confusional states, memory dysfunction for up to a few months after treatment, and persistent memory deficits for the time around treatment.
Thank you very much. That reminds me, if any of you have any written statements about the consensus document you'd like to submit them, please feel free to do so. The gentleman who's had his hand up in the middle of it.
Small from Indianapolis. On the question of brain function and ECT, we've done Halstead Rayban testing and Wexford testing for approximately 18 years on ECT patients. We have data on hundreds of patients. We've done follow-ups up to 7 years on many other patients. We test prior to ECT, after ECT, and in follow-up studies. We also rate patients clinically in a blind manner. We find prior to ECT, with these measures of brain function, patients are functioning in a brain damaged area. We find post-ECT that they are functioning nearly a normal level, not quite. We find on follow-up, if they're still well, that they're functioning well within normal range.
They want to ask what it is about. I'd like to see.
Dr. Langston of Washington. First of all, I want to congratulate the panel on a generally excellent report on an extraordinarily difficult subject. While I do not agree with everything, I think that it is an unusually fine effort, and I'm sure it will be sharpened with time. I want to just add one item on page 7. As a clinician who has administered ECT, in the paragraph, we'll do the third paragraph, the one just above the last one. You mentioned here that the time it takes to recover memory, to recover clear consciousness, which may be several hours, varies depending on individual differences in response, the type of ECT administered, and the spacing and other treatments given. I would like to suggest that you add also the age of the patient, because I think this is also quite critical.
Dr. Brigham?
I want to show appreciation to the panel for honestly working on the issue of memory deficits and for honestly describing the confusional state. Too often these issues have been glossed over, more so, and I really do want to show some appreciation for your working on these issues. I think it's an advance in psychiatry to have these things written down. This is the area that you asked me to testify on, and I do have one specific area where I feel that my lengthy testimony was simply disregarded, so I'd like to take a minute and just review it. And that is your statement on page 9 that neuronal death has not been detected in animal studies. This is simply false. We have several excellent studies, and if you would like me to review them more or ask me about them, I would. But it flies in the face of the study by Hartelius, which is book length with controls, which shows cell death. It flies in the face of studies by Racine and others at the Columbia Psychiatric Institute, which show cell death and which show hemorrhages. Since I was asked specifically to testify in this area and written a book about it and review the study, I would hope that at best that sentence would be deleted since it's false. I would prefer to see the statement that they do show self-death. If any of you would like to discuss that issue with me briefly when I'm done, I would be very happy to do that. In general, I affirm Dr. Squire's changes, some of his changes. I'd like to suggest one minor but important one, and that is you state that many patients complain that their memory is not as good. In medicine, patients complain and doctors report. I would like to see that changed to patients report.
What page?
Page 8. Page 8, fourth from the bottom. Many patients complain. Complain is a pejorative word in the dictionary. If you looked it up, it would not give much credence. And you can tell the patients in the audience appreciate it. Now, I'd like to make two suggestions on the memory gap issue that will be additions basically to the ones that Dr. Squire made. And I think they're very critical, but they're minor in language. On page 8, enduring and permanent memory gaps have been reported to occur for events occurring in the 6-month period before ECT. Even in Dr. Squire's work, that 6 months represents the mean or the average. I'm not sure which. The mean or the average. That means that the memory defects go much earlier than the 6-month period on your bell curve, even in his conservative research. So it's not during the 6-month period, it's either for a mean of 6 months, or more accurate, more easily, you might just say for a period of at least 6 months. This is quite critical because his research and others have clearly established that the 6-month period is the mean, and I've seen many patients with losses extending back a year or 2 or 3 that are quite significant. We've had testimony here from patients who've lost college educations. That's not inconsistent with a 6-month mean or average. It is inconsistent with a 6-month period. And similarly, the retrograde amnesia and for the 2-month period after treatment for anterograde, it should be for at least a 2-month period. The 2 months is again a mean or an average, as far as I understand it. And perhaps that's why I can exchange briefly on that, since he's come up with the microphone.
I think that's a fair point. These were median figures representing 50% of patients reported more, 50% less. So I think the terminology at least would not be appropriate because after all, half of the patients reported a less severe experience. But I think the wording occurring during an average of 6 months before and an average of 2 months after would be a fair statement.
Would Dr. Lefnick like to respond to Dr. Brigham's discussion of the neuronal cell death?
We considered the weight of all of these studies, and I think the sentence preceding what you stated sums up the feeling or the consensus, and that is that in looking at the studies that have been controlled for a number of problems, there is no convincing evidence for neuronal cell death.
May I ask directly if anyone on the panel has read Hartelius' book length report? Direct question. Has anyone on the panel read Hartelius' book length report?
Well, I think it's very difficult to out of the hundreds of studies that have been done, to use what I would consider a very selective critical review, and certainly there are a number of studies and findings recently by Meldrum and others and all kinds of species of animals that I think outweigh the evidence of a single study which was done at a time when there were problems with methodological results.
There are no studies after that other than the rat studies by Meldrum, and not on a variety of species. We are weighing one series of rat studies against trained, highly qualified investigators in Colombia on monkeys. Artelius was extremely good on cats against no other studies other than rats who were notoriously insensitive to hypoxia. I really feel that in the interest of scientific accuracy, the statement should at least be deleted.
I think we'll have to move on to if there's any other, we are faced today with less pressure because of what? I'm sorry.
I think I would like to comment on the Artelius study, which Dr. Braden and I both seem to be very fond of. But I think that we're reading different pages. In fact, you talked about the ghost cells, which he found in the animals who had had seizures. But in fact, he found it in the controls as well, the ghost cells. While he found dark neurons to be increased in the animals who had had seizures, and as he were not using the perfusion fixation, and in fact cutting the blocks in the soft brain tissue, I think that he also himself mentioned that it might be artifacts and not doing solid seizures.
May I respond just briefly?
Yes.
Thank you. Artelius had 57 cats, 41 shot, and 16 controls not shot. He used only 4 to 16 shots. He had complete double blind. This is not an artifact problem. He is reporting from a totally double blind study. Nobody knew which animals had been shot and unshot when they were looked at under the microscope. And he lists changes in cell walls, acute edema, multiple temperatures as his findings, including cell death, which he specifically cites, as do the Columbia studies. And to quote, he says, the question of whether or not irreversible damage to nerve cells may occur must be answered in the affirmatively. This is the very best study, but it also confirms the studies out of Columbia.
Dr. Warner?
As Dr. Bregan knows, I made an extensive review on this topic, which was published in the Behavioral Brain Sciences last year, which, if you account for the fine print, really also amounts to book length, and was commented upon by a great many individuals, including neurologists and neuroscientists. In my very careful reading of the entire Artelius article, it was very clear that Artelius himself felt that any degree of irreversible cell change was minimal at best, and he was singularly unimpressed with the degree of irreversible changes that occurred. These are words that he used themselves, despite the quote, which Dr. Bregan is desperately looking for now, which Artelius later contradicts himself in the same article.
What was it standing up there for some time? I'd like to call an email.
Thank you. I'm Helen Field, Irvine, California. As member of the Republic and also member of the Committee for Truth and Psychiatry group. I have an anecdote for you. That is to say, again, an ancient form of truth. There are many forms of truth. Specifically, I'm here today to show you in your own terms what I think is your conclusions. There are many forms of truth, some ancient, religious, artistic, philosophical, and modern scientific experimentation. The scientific method is only one form of truth. Next, to find truth, I have a modern anecdote for you, which is as a detainee in one of our large American concentration camps called mental hospitals, I was talking to a man with no legs who had spent 2 decades there selling papers. Previously, he had done the same on the streets. I said, I can't remember his name. I have that lady who's been shocking. I said, what do they think is wrong with you? Mary said, they don't think. Thank you.
I think we'll have to move on. We have about 40 minutes left to cover the other three areas. And the next, is there, Dr. Stackhouse, is there some egregious error that you're feeling we are creating, or was discussed? That stand up and shout the world. Tell us what we're doing.
Well, on page 7, you suggest that there's an association between the magnitude of the blood pressure increase and the presence of essential hypertension. And that's in the middle of page 7. And there, in fact, I don't think any data suggesting that. I think that that would be an error, and that it would be more appropriate to say in that context that the rise in blood pressure may be particularly concerning patients with essential hypertension. Not that the response is more severe in patients with essential hypertension. Whatever data there are to indicate the correlation zero. Then the other point, which I think is more of consequence, is that there is considerable data, something which was presented here, that indicates the other aspects of cognitive functioning other than anterograde memory and retrograde memory, in particular aspects. We either see no change or improvement in the patient who receives ECT. And I think that the statement at the end that there's no consistent evidence of change in other cognitive functions does the assertions of the sort that Dr. Small is indicating.
Can you say that again?
That the field suggests that in areas other than particular aspects of memory function, when we look at, for instance, sensory processing attention.
You're suggesting the word absence rather than no?
There's either an absence of change or improvement. That's what the data is.
Thank you. If I could permit continued discussion of this, when we won't get onto the issues of policy, informed consent, et cetera, which I think are very important issues also. So I would ask that if you have if you would like to point out where we are making a strong, a very important error or not so very important error, if you put it in writing, it would be very helpful. We will try to use that before our press conference, and I appreciate your patience and allow me to proceed. Next is the
Excuse me, I've had my hand up off and on, and you saw me raise my hand about 10 minutes ago, and I still have not been recognized. A very important observation question to make on the risks section in your draft report. It's probably the only time I've been able to raise it. And I think it's unjust for you to deny me that opportunity.
Make it please, sir.
Thank you. Page 9. Okay, the whole bottom half of page 9, where you presume to say a definitive word on the brain damage, which you actually do. You don't call it brain damage. You say the artifacts. What I resent is the fact that this is one other example of the fact you don't recognize brain damage, which is a direct result of electroshock. You minimize the many credible studies that have been done on animals and human beings. We're talking about the autopsy studies and clinical neurological studies conclusively showing brain damage. It's, I heard and read Dr. Wiener, and he himself misinterprets Hartelius, which is the classic study on brain damage, conclusively showing that brain damage is in fact a direct result. And secondly, I gave you, and I don't know whether you have it, about a day ago, a shock bibliography with special references to brain damage documented in the literature. Do you have that? I gave it to your colleague because he said he would give it to you right on the panel. It was yesterday afternoon. It's 18 pages long. It documents the brain damage from shock, modified shock, unmodified shock, permanent memory loss, neurological studies, all showing conclusively there's brain damage. Now, do you have that?
I have the document that you provided. Yes, it was provided to us. Thank you.
Fine. Once again, this is a whitewash of the serious damage from shock. It's like the APA.
Dr. Miller, I think is a very important point he wishes to make.
It's a generalized comment, and it relates, I think, to the risk and benefit of the treatment. So one can't address it to single section of this document, but I think that there is a void in this document, but the issue was discussed yesterday, it was raised by Dr. Weiss, and it is that you really should describe in the introduction the course and the devastation caused by affective disorders. And that affective disorders are lifelong, they are quite common, and they are life-threatening in the sense that they are equally severe as many cancers. It's well accepted that many cancer treatments cause great damage. Compared to those, ECT is not a very damaging treatment by any account. Furthermore, I think that it's fairly well recognized today that different strategies may be used for the stopping of an acute life-threatening episode and for the maintenance treatment. That's not clearly mentioned here. ECT is clearly efficacious in the stopping of a life-threatening
Dr.
episode.
Miller, we did discuss efficaciousness in the third section.
If you then put the patient on an adequate maintenance treatment, you actually may reduce the need for further ECT. And I think that those points should be made very clear in the public record.
I'd like to go on now to the third area, if I may. What factors should be considered by the physician or patient in determining if and when ECT would be an appropriate treatment? Yes, sir.
Dr. Oberlin, University of Maryland. I'd like to get some clarification on page 11, a paragraph that is non-responsiveness to other treatments. It's not totally clear to me whether the panel is saying that ECT should not be used as a first-line treatment in any case, or only only after non-responsiveness to other treatments has been shown. And I'd like to get clarification on that. Secondly, I would like to suggest a modification of one word in the first sentence, if that indeed is what the panel is suggesting. And rather than using the word alternative, that is, ECT should be considered an alternative, I would suggest substituting for that, ECT should be considered when other known effective pharmacologic and or psychotherapeutic treatments have been tried. Thus, the word alternative could give rise to the use of a lot of treatments that are not known effective for the serious conditions for which ECT is being considered. But, of course, the change of that sentence is contingent upon a clarification of whether the panel is saying that you must have other courses of known effective treatments prior to considering the use of ECT.
We struggled with this question long and hard, and the result you see is, I think, the difficulty it involves in our inability to arrive at a consensus on something more specific. I think the feeling is that the conditions are so specific to particular clinical situations that we could not abstract clear-cut indications for when ECT would be a first line and when it would be a second line endeavor. So that what we've suggested here is that the non-responsiveness to other treatments is just one reason why ECT may be used, but the other indications listed along diagnosis, medical indications, and contraindications might result in a clinician using ECT as a first-line treatment. We haven't spelled it out clearly, and that's a problem.
Perhaps then not using a separate heading for this paragraph might be helpful, because I misinterpreted that, I guess because of the separate heading.
Thank you.
And also the possibility, again, of changing the known effective treatments for those disorders would be consistent with what you said.
Yes, the gentleman back there. Yes, sir, please. I don't remember your name, I'm sorry.
Dr. Peterson, congratulations likewise for such an excellent effort in such a short time. On page 11, the first paragraph, using ECT in most of these conditions when the overall risk-benefit analysis has been made. In my humble assessment of the risks, the increased intracranial pressure might be the only absolute contraindication. But again, risk-benefit analysis in any general circumstance is the appropriate approach rather than an absolute indication of non-indications. Now, the issue of the performance standards, I appreciate the committee needs to rely upon data for most of the conclusions or suggestions for needs for data, but the data from the long of informed consent regulation in California reported for 7 complete years for more than 15,000 patients, for about 100,000 treatments, reflects that the use, I'm referring to page 13, and the application of court proceedings for the patient lacking capacity to render their own decision for treatment. The no-holds barred endorsement of court proceedings, I think, should be modified in view of the available data. And again, I would remind the panel of the data that was provided to them in writing of the numbers reported by the California Department of Mental Health. If we're talking about quality of life outcomes, death, I think, has to be considered one of the important criteria for quality of life. 2 deaths have been attributed to ECT during those 7 reported years. 28 deaths have been reported attributed to regulatory obstruction of ECT during only the first 4 of those 7 years. This is published by the Department of Health. In almost all counties of California where hearings have been held for ECT consent purposes, the courts and the legal officials involved have never obeyed the time guidelines of the statute. Physicians are under the threat of penalty of loss of license if they are not obeying the consent procedures. Public officials have never been censured for delays of even months in writing a court hearing. So I think even if the recourse to court proceeding is considered desirable, then there must be an allowance for urging for emergency treatment. Perhaps, as one of the speakers suggested yesterday, medical and maybe family decisions in the urgent situation might be allowed to proceed in life-threatening or health-threatening circumstances with a subsequent court hearing typically held as they are already at the time and convenience of the court system.
Can I just ask a clarifying question? You were suggesting that for the category of patient who we've identified as without legal competency to consent, that there nonetheless should be an exception for emergency application?
Absolutely. It seems really unusual for a consideration of health and human welfare to not reflect an important concern for life and death.
I'm looking for the audience of those people who made presentations specifically related to this area, who have been talked several times already. Dr. Roth. I almost lost the time.
Just 3 brief, extremely brief comments. I agree with Dr. Peterson that it was helpful to say timely court hearings. This timely court hearings. This can be an incredible bother with the courts and really take inordinate amount of time. So I believe in court hearings to legally adjudicate the controversy, but I believe that they should be timely. The second point, which is a clarification, I think that the suggestion about repeated consent is obviously an excellent one, in the sense that repeated information procedures are necessary and repeated consultations, and I think our own data suggests that. The question I have is there's a tendency to bureaucratize these issues about repeated consents, and whether the intent of the panel is that after each and every treatment, another informed consent form should be signed. I think that should be avoided, because really not feasible. I think the patient needs continuing information about the treatment and continuing consultation. I would not contemplate a procedure with multiple signed informed consents. And there is the last problem that Dr. and Mr. Kari alluded to. At times, the patients become relatively less confident during treatment. You have another kind of bottom here. So I would watch this very carefully about the repeated consent.
You want to respond? Anyone on the panel want to respond? Okay. I believe that the back there has not spoken yet. Yes, ma'am.
My name is Jennifer Rubel, and I work in a state facility in Virginia as a patient advocate. And I'm particularly concerned about the comments raised on informed consent on page 13, and I'd like to add to the comments that the previous gentleman made. In our state facility, physicians are not required to go through a court proceeding to determine the legal competency of a patient. They themselves clinically determine that. And my primary concern is that patients who are particularly involuntarily committed to state facilities can very easily be coerced into receiving ECT on the basis that if they refuse any other form of treatment, I have observed them suddenly deemed incompetent, and then the procedure for providing them with ECT is really something that they have no opportunity to refuse. And I would suggest that the panel in some way, in whatever language they feel comfortable, please raise the issue in the context of informed consent that they are opposed to any coercion of patients, particularly involuntarily committed patients in facilities, because that, I think, is a very serious risk and one of the main reasons that I'm opposed to ECT.
Yes, only the glasses.
Thank the panel who spoke in the past 3 days. As far as what Dr. Roth was saying about continuing informed consent prior to each treatment, in my own experience with ECT, the physician administering ECT asked me to sign an informed consent prior to every treatment. I thought it, in a sense, was kind of silly because I was very grateful for the treatment. But at the same time, I appreciate the panel including the statement because I do think it's very important. Also, that's all. Thank you.
Ms. Chamberlain.
Thank you. I have 2 comments on section 3. The main body of my comments is on the informed consent procedure, but I do want to start with page 10 of the last paragraph, which seems to indicate that present suicide. I think we've got the data from presented to you that there is no evidence that ECT prevent suicide. ECT may cause at least suicide. Prevent. Allegedly prevent. As far as the and I think that's right. As far as the informed consent section, I'd really like to congratulate the panel on paying such careful attention to informed consent, because this is, at the next to last figure indicated, and Mrs. Ribble indicated, extremely significant area, not just in the case of involuntarily committed patients, but in the case of anyone in a psychiatric institution who can be involuntarily committed by administrative procedures in most states, and refusing proper treatment is a very, very common indication. So I think you have to look at the coercive atmosphere and not just
involuntary cases, there are a number of studies that show that in practice there is very, very little difference between what happens to so-called voluntary cases and what happens to involuntary cases. We really ought to consider that very carefully. As far as the speaker from California who talks about the slowness of court hearings, in Massachusetts we have procedures that require court hearings for every incompetent patient before they can get psychiatric medication. Not just people who are refusing psychiatric medication. Every incompetent patient must have a court hearing. And we are able to do that in a timely manner. The answer is not to permit bypass of the court hearings. The answer is to require the courts to do things in a timely manner. We can do it in Massachusetts. There's no reason why it can't be done. In your section where you talk about the unduly restrictive categories being for involuntarily committed patients, I think you once again in that circumstance particularly, you've got to pay attention to this coercive pressure that can be brought, but you've got to broaden it out and say that coercive pressure can be brought on anyone in a psychiatric hospital. People in private psychiatric hospitals are very often urged to consent to or coerced to consent to ECT through being threatened that they will be transferred to a state hospital. Patients who are offered ECT on an outpatient basis are often asked to consent on the proviso that otherwise they're going to find themselves involuntarily committed. So you've got to look at the entire coercive atmosphere question.
Dr. Davidson.
A brief objection to the bottom paragraph, page 13 of the paragraph. It may be desirable for physicians with patients for whom the prospect of ECT is a foreseeable but not immediate possibility to discuss this in advance with the patient when his or her judgment appears at least compromised by the underlying disease process. Now, as a clinician, I submit that this is ridiculous. That is, to discuss the possibility of ECT with a patient would increase their anxiety 100-fold and make it further. In some cases, it is possible, but it is rare. I would at least suggest that that you add a sentence there and say this. Discusses in advance with the patient when his or her judgment appears least compromised by the underlying disease process. Then add the following. And when such discussion is judged unlikely to produce disabling anxiety. Thank you.
Anyone on the panel want to comment on that?
I'd just like to make a brief comment that one of the purposes in doing this whole section on informed consent was to try and make available to patients all the available options that they may have. All sorts of options may create anxieties in patients. I think it's very important to get away from a paternalistic notion of medicine. That just because some anxiety may be brought up in patients because of a particular treatment doesn't mean that the possibility of that treatment ought not to be made very clear and explicit to the patient.
Marilyn Rice and then
Thank you.
Dr. Weaver.
I'd like to speak to the matter of informed consent, which that is the matter that my organization, Committee for Truth and Society, is particularly concerned with. What's really crucial in informed consent is what are the pros and cons that you hand to patients by some sort of a statement of patient information. Well, that hasn't come up here at all. But I would like to call the group's attention to the fact that it is an issue over at the Food and Drug Administration, which has responsibility for consumer protection in medical matters. Some time ago, they announced that they were at least considering sponsoring a statement of information that would have to be given to patients before they come for it. Now, they haven't decided what that statement should say, but there have been two statements proposed. One was proposed by the American Psychiatric Association, and it was prepared by doctors who give this treatment. The other proposal was made by the Committee for Truth and Society, which is a group of 68 persons who have had this treatment. These statements are quite different with regard to the matters of brain damage and permanent memory loss. Anyone who's seriously interested in this subject could pick up on the table outside the two statements. They work together, they can both be read. But this is a practical matter. The people that have had this treatment, what it boils down to, they're furious because the doctor did not tell them that this was going to happen to their memory. This being what happened to the memory of the 68 people.
You pass. So you want to yield to the gentleman there with his hand up.
I'm a neuropsychologist from Baltimore, and I have not given or been associated primarily with ECT patients, but for 30 years I've seen the effects of other traumatic insults to the central nervous system. First of all, I want to also express my gratitude to the panel for what I think is a well-balanced presentation. But I would like to support what this lady said about reading two statements put out, one by professional organizations with which I'm associated and one by the patients. And I would say that in balance, I wholly subscribe to the patient's point of view on this particular issue. And I would just like to briefly outline why I do so. The reason is that we have invented a new word, which is anterograde memory, which is sort of a contradiction in terms, really. Anterograde memory means that we are talking about recording information, putting it into a dynamic working memory, retrieving it, associating it with old information. In other words, all the things that have to do with thinking efficiently. And what these folks are saying is that a significant number of them find themselves not thinking efficiently. And Small from Indiana indicated that his scores indicate that everybody is okay. Well, my scores on neuropsychological tests also indicate that everybody is okay if I use the right hand or likes the full-scale memory. But if I keep track of all the symptoms that people have, they're not okay. They tend to be a little bit more concrete. They tend to perseverate. They tend to disassociate. They tend to be a little bit more forgetful. They tend to be a little bit more flaky. They tend to do all sorts of funny things. Now, these are not funny people. They're serious people who want to go through life. And if you want to know how it affects the quality of their life, it may not affect it on an IQ score, but would you want to marry somebody who is just a little bit flaky, who is just a little bit forgetful sometimes, and so on and so forth? So my point is not that ECT is bad. We're talking about trading symptoms. My point is that neuropsychologists, in particular in my profession, ought to get off its backside, not give summary scores, but instead keep track of symptoms and do some decent epidemiologic research to find out what really happens to people. Thank you.
Can we go on to the final 2 seconds? We only have
No, Dr. Rose, I'm an invited speaker, and to exclude me when you're having non-invited speakers speak twice is hardly fair and is consistent with your attitude of the panel. You had Dr. Levinson speak twice. You have no role here, but as a famous PR person for shock treatment, you ought to allow your invited speakers to comment. Thank you, and please stop being rude. Now,
it's better not.
two basic. Yes, and please select me on the final section when I raise my hand as one of your invited speakers. There are two issues I want to address. One briefly is that your own report indicates that electroshock is A, controversial, B, causes memory loss, and C, causes a confusional state. want it on the record, it should be a part of informed consent. Now, the issue of suicide, your report is shameful in this area. You have before you the only two studies that the shock advocates produced claiming that suicide is reduced. You have them in front of you because I Xeroxed them after the shock advocates promoted them as proving that suicide is reduced. And each of the studies by Avery and Winter show that shock is no better than no treatment at all. The studies show that shock is no better than no treatment at all. This is very, very clear. I challenge Dr. Fink and every other member of the speaking group to produce a single study that showed that shock treatment helps suicide. None were produced. It's a travesty to break your own rules of controlled studies, which you advocate and which you try to follow in your beginning sections, and to simply go along with this repeated fallacy that shock treatment improves suicide. It's a shameful part of your report.
I'd like to move on to the last 2 sections. We have 10 minutes more, and the lady who spoke yesterday on the panel about the ECT devices. This is how it should be administered.
I would like to suggest the addition of one sentence in the paragraph at the bottom of page 16, which begins the panel believes that it is imperative that appropriate mechanisms should be established to ensure proper standards and monitoring of ECT. On page 6, she made several references to best equipment and modern equipment, and I think in this paragraph you should add references to the quality of the equipment as well as to the references you have made regarding the use of the equipment by the practitioners. Specifically, right before you talk about periodic inspection of equipment, before you can rationally inspect equipment, you should have some standards set for the minimum safety and efficacy of the equipment. This is what the FDA probably will proceed to do. There are no standards set now in the marketplace, and therefore even the best intentioned physicians might find themselves in a facility that has very outdated and outmoded equipment. Therefore, I would suggest that you add in, at the point I mentioned, the sentence which would read something to the effect, legally enforceable performance standards must be established to ensure that all ECT equipment meets acceptable levels of safety and efficacy. I'd just like to make one other comment, too, that it's interesting to me, and I don't know why it is, that there aren't any representatives of the manufacturers here. One would expect that those who market this kind of equipment would have research and development data on some of those technical features, and they have been conspicuously absent in the last decade during all of this debate, and so I think it's imperative that you address it.
Could you repeat your statement that you suggest we put in a little more slowly? We'll probably get it down.
Legally enforceable performance standards must be established to ensure that all ECT equipment meets acceptable levels of safety and efficacy.
Thank you. Gentleman over there, who has not spoken yet, our colleague.
My name is Leonard Roy Frank, San Francisco, and Monday I addressed the panelists. I'd like to support the statement by the psychologist from Maryland regarding the tests that are under scrutiny here. They're not really at all sensitive to the real losses that people with shock treatment experience. Myself had a lot of it. I can tell you, I've been sitting here for almost 2 hours now, going over in my mind the different points that I would like to raise and the difficulty that I have in getting them together to even stand up to this microphone because of the injury that has been done my brain. That's never going to show up on any test. And that's the experience of hundreds of thousands of human beings over the years who've had electroshock. You're not testing for it. You have not heard and received any documentation affirming the effectiveness and safety of electroshock. And here you are supporting it without the double-blind studies that even the scientists you should require before you would endorse such a procedure as electroshock. You are endorsing something that has been experienced by hundreds of thousands of human beings as the most horrible things in their lives, the things that have reduced their quality of life and have made them less effective as human beings, and made it more difficult for them to stand up in situations like this to protest about the continuation of this barbaric treatment. You know, looking back on this maybe 2 or 3 or 5, 10 years from now, when it is recognized by everyone that electroshock was a monstrosity, you people are going to be looked upon as those who endorsed this procedure. And you came up with some technical findings about this and such and such and such should be done. When the whole issue is at stake here of brain damage and of the reducing of the quality of life for hundreds of thousands of human beings, and you're not dealing with that at all, Harvey. Think about what you're doing. Think about your association with this kind of endorsement. And what it means to so many people.
We have 7 minutes more before we have to go. I will give you a second.
Speak to the truth, and the rest of you don't.
Dr. Pippard, raw conscious psychiatrist. Very quick one. You're recommending on page 15 that there should be continuous monitoring of the EKG, blood pressure, and pulse throughout the procedure. In our survey in Britain, I found that no one monitored the EKG, the blood pressure throughout the procedure. It was used occasionally. In fact, in 180 clinics we visited, we didn't see it in use. And the apparent danger which results from this is negligible. I hope that it will not be put in that this was an essential part of the procedure. It's a non-helpful addition to what is clinically a very safe procedure.
Go ahead. I'm sorry, Kathleen.
Do you suggest we delete the whole sentence then, the EKG blood pressure?
Yes, I suggest delete it.
None of that should be monitored.
No, none of that should be.
How about a fine?
Yes. Yes.
Why? Because they don't do it in Britain?
No. There is greater danger from intervening with the minor cardiac irregularities that occur than by leaving them alone.
Yeah, I'd like to make 2 points to eliminate from this section. On page 15, in the last paragraph,
Yes, I can't hear you.
yeah, on page 15, in the last paragraph of that page, there is discussion of the issue of optimal frequency of ECT administration and the optimal number of treatments. At other points in the report, this issue is alluded to too, as well as the importance because of the relationship to memory and other cognitive impairment parameters. Now, you make no recommendation at this point as to what is the optimum frequency of treatments and what should be the total number of treatments administered. And really there are quite wide differences. And it is my suggestion that this is the case because there really is no definitive information upon which to base such a recommendation. And I would submit that there should be this should be included in the section on dealing with future research direction, the point number 4 on that page, which relates to the need to study mode of electroreplacement stimulus parameters. And I would submit that should be included at the start, frequency and optimum number of treatments.
Thank you. Dr. Small.
Pardon me, I need to ask you, do you think we should delete them 6 to 12 treatments? I don't.
No, certainly
No,
not.
it's okay.
I think that it should be clear that there is no definite consensus as to what is the appropriate number of treatments to administer, how frequently they should be administered. And I think that the section dealing with future research should simply note the need for this under the heading which deals with other areas.
You place no limit on the upper range, Dr. Barrett. You place no limit on the upper range. You say 6 to 100?
Certainly not. I believe that 6 to 12 treatments is the range of treatments used, but it is quite conceivable that 6 may be sufficient.
I understand.
That has not been established. It is
but I know he's clear that Melbourne needs.
We have 3 minutes. Dr. Small has not spoken. She was a speaker. I'd like to have her comments. And Dr. Friedman, probably make it brief if you can, sir. Ma'am.
Point of information for Pat on page 14. You say essentially lithium-free. Data available indicate that toxic reactions occur when the patient is on lithium concurrently or it is discontinued within just a few days. I think you can be specific and say a week without lithium.
Thank you. Dr. Friedman.
Two very small points. On page 16, paragraph 2, you suggest that there should be a national survey of the status of ECT treatment, which I assume is a sort of similar study to the Piffard-Mellon one in the UK. Then on page 17, the first recommendation for immediate research is a national survey of patient attitudes and responses. And I want to clarify whether you think well, I think it would be better then on page 17 that was made clear, because as it reads, it is just a survey of patient attitudes and responses and not the practice of ECT, which is what you recommended on the previous page. So I would suggest you add in a statement, a national survey, which has the basic fact about patient attitudes, response and the practice of ECT in the United States.
I'm going to have to stop. There are a number of hands that are up. I apologize for not calling on you.
There's a travesty in this report that has to be addressed.
We have to leave. We have to go on to. Yes. Put the comments, I've asked that several times, I thought that was clear, I apologize. I thought if you could put what you consider to be very important issues in writing, they'll be brought to us over the next hour and a half. This is the official and formal close of this particular section. There will be a press conference for the panelists in approximately 2 hours. Thank you very much for your attention.
Where's the press conference?
I think that we have a right to know where the press conference is going to be, Dr. Rose. I think the public has a right. This is an open press conference, presumably. Is there anyone on this panel who cares to divulge where the press conference is going to be? Do we have a right to know this? Are any of the people here dissatisfied with not knowing this? Is this important fact?
Where's the press conference?
Where is the press conference?
Why are you promising Why are you
Only for the press. There's no one else, because the press is asking us questions. The press conference is here on the NIH campus.
Are you a member of the involved press?
Dr. Ducali, about the press conference. Let me just, please, the press conference will be held at the Lister Hill Center, but I want to emphasize that the press conference is for the press. Others will be permitted on a space available basis. The press will have first priority to the space at the Lister Hill Auditorium.
Dr. Rose accepted 2 pieces of literature for reference. I would hope and might make copies available for the panel. We're talking about having a police factor information on the device and what we're using. And the one copy is the Thymatron, the brochure on a single sheet handout on the Thymatron pulse ECT device. And in there it shows the physical characteristics. The other also included a current Winchester ammunition catalog because it shows the energy with which the bullets have.
All right, out with your gun. Out with your gun.
Okay, this won't hurt. It'll be over in just a moment.
Uh-huh.
What's that?
Conductant.
Oh, dab will do you. Right, Mr. Jackson.
Open your mouth.
What's that?
This will keep you from biting your tongue.
Oil?
Now just bite down on it. That's right. Just bite down. Now bite down on it.
Are you ready?
Ready.